we go on to our next speaker, Dr. Mallika Goyal, again, a very dynamic retina vitreous and uveitis surgeon. She's a senior consultant and heads the department at Apollo Eye Hospital, Apollo Health City, Hyderabad. And she is going to take the whole session to a different direction by talking on decoding neuroretinitis. So on to you, Dr. Mallika.
Yeah, good evening, everyone, and thanks, Dr. Chitra, for this opportunity. After listening to those wonderful talks, I'm a little dazed. I'll speak about whatever is my experience with neuroretinitis. To begin with, it is an inflammation primarily of the optic nerve and neural retina. Initially, the focus was on the hard exudates, but then it was Gass who showed that disc edema is the primary pathology and precedes the macular exudates, and hence he suggested the term neuroretinitis. So the earliest sign is optic disc edema, which causes leakage of fluid and lipoprotein from the disc, which migrates into the macula into a star pattern because of the Henle's fiber layer, which is arranged in a radial way. And the star starts forming only after 2 to 3 weeks of the onset of symptoms. Also, fluid from the optic disc is able to go subretinally and cause a serous detachment of the macula. So optic disc edema and macular fluid or a serous detachment are the first signs to be seen. And the exudates come in 10 days to 14 days later. The disc edema and the fluid get absorbed very rapidly in the first 2 weeks. So they may not be there when the patient, if the patient is seen later in the course of the disease, but the hard exudates take longer to go. The hard exudates typically start becoming visible when the disc edema is already resolving or resolved. This is one patient who had a peripapillary lesion with a severe disc edema and initially came with 2/60. There were no macular exudates as you see at this point. He was treated with steroids with little benefit. Vision was 2/60. So we, based on the CT chest, the pulmonologist felt that he could start ATT because everything else was negative. And there was within a month, he had improved to 6/9. And at this point, the disc edema had gone, but now you can see the macular star. And 2 months later, the star has also gone and the disc edema has also resolved and he's still on ATT. This is another lady who came 2 weeks post-fever. At least 50% of these patients are post-fever or some such febrile illness and rash. And based on various investigations and the history, we assumed it was rickettsia. And she was placed on oral steroids with doxycycline with good resolution. You can see the vision was 1/60. And post-treatment, she was 6/24. Again, starts with fluid at the macula and some disc edema. Macular star is coming in after 10 days. And after 3 months, everything has resolved. But there is some atrophy of the fovea and some optic atrophy. So it could be a direct infectious invasion of the nerve or an infection-induced autoimmune response. Microorganisms have generally not been isolated from the ocular specimens, and serological evidence of an infection is usually lacking. So it's either infectious in origin or autoimmune. Infectious in origin, most of the Western reports talk only about cat scratch disease as the cause, Bartonella. But in India, I think it's Mycobacterium tuberculosis, as I showed in one case. Also, rickettsia seems to be very common. Toxoplasma, spirochetes, very important cause, syphilis, Lyme disease, and leptospirosis. It could be fungus or nematodes. And it could be viruses, chiefly herpes group or CMV, but also dengue can cause neuroretinitis. As I said, in the Western literature, it's mostly cat scratch disease, which is acquired by contact of cat saliva in coming in contact with a patient's open wound, which could be a scratch or a bite from the cat itself, and the TB. This cat scratch disease is seen mostly in young, otherwise healthy individuals, and they have this whole host of symptoms. There can be a bite mark and surrounded by a rash, painful lymphadenopathy, fever, and fatigue, etc. And the treatment is with steroids, with or without antibiotics. And the antibiotics are the regular broad spectrum antibiotics, including azithromycin and fluoroquinolones. typical of spirochetal neuroretinitis could be an associated severe anterior uveitis and meningeal or cerebral involvement. Also, bilaterality is more commonly seen in spirochetal neuroretinitis. It could be autoimmune, chiefly sarcoidosis, SLE, or antiphospholipid antibody syndrome, PAN, and the TINU. This was our patient who, she is also a doctor, 55-year-old. She had a very prolonged severe systemic illness, delay in diagnosis, treated initially for several weeks as infective disease with meningitis, but turned out it was an adult onset Still's disease. So there was a lot of delay in starting steroids. And by the time she came to us, there was a further delay of 4 months because she was unconscious, so she didn't even know she had lost vision. So by the time steroids were started, she already had optic atrophy and foveal atrophy. So this is another important cause for neuroretinitis. It can be classified as infectious, idiopathic when there is no cause found, and idiopathic with recurrence. Idiopathic is a diagnosis of exclusion seen again in healthy young subjects with good prognosis. Steroids do not seem to alter the final visual outcome. It's a self-limited disease. When it is recurrent, macular star may not be evident, and if it is present, as you can see in the picture on the right, it may not be in a star pattern. It may be peripapillary or any other location of the exudates. Obviously, when there is recurrences, there is increasing damage of the optic nerve and poorer prognosis. So longer-term immunosuppression would be required in these patients. Now, this is a recurrent patient. We saw this February. He already had an event in September. So when they develop lipid exudates, it is in the peripapillary location and not in the classical macular star appearance. But the vision was still good, 6/6, and we still treated him only with topical steroids because there was no obvious inflammation. Now, how does neuroretinitis differ from a regular optic neuritis, which is the demyelinating type? Neuroretinitis is not associated with an increased risk of multiple sclerosis. So if we see macular star in a patient with disc edema, that may predict less chances of developing multiple sclerosis, which in our country, however, is not very high. Importantly, also, relative afferent pupillary defect is less prominent in neuroretinitis than in a regular optic neuritis. Now, it can present at all ages, but more commonly in the young people. No gender predilection, usually unilateral, but can be bilateral. Importantly, the vision loss is painless, unlike the regular optic neuritis, which starts with painful vision loss. And the vision at presentation can be very good, 6/6, or it can be just light perception. Color vision defect is common. RAPD may be present. And as mentioned, now important is to look for inflammatory signs so that we can differentiate it from a regular optic neuritis, which will not have vitreous cells, venous sheathing, or a mild anterior uveitis. Similarly, papilledema is unlikely to have inflammatory signs. So this helps to make a diagnosis of neuroretinitis if we can pick up some signs of inflammation. Now, since star appears 2 weeks later, it is important to examine any patient with papillitis or disc edema after 2 weeks because that would change the diagnosis. Sequelae could be optic atrophy and RP atrophic changes, or these may not be there. I mean, there may not be much loss if it's a idiopathic type with good prognosis. History should include pets, bites when the pets, tick bites, history relevant to TB, syphilis, HIV, cough, lymphadenopathy, and exposure to flood water, etc. External examination for herpetic lesions, skin lesions, color vision, vitreous cells, and anterior segment inflammation. Perimetry classical is secocentral scotomas, though it could also be other types like central scotoma, arcuate, or altitudinal. VEP is expected to be abnormal, but ERG is normal. Investigations should be tailored to the history and findings. ESR is important, as also infections. Basic investigations should be for TB, syphilis, Bartonella, rickettsia, Lyme disease, leptospira, viruses, Toxoplasma, Toxocara, and a basic autoimmune panel covering sarcoidosis, SLE, PAN, and GPA or vaginas. So these are the basic investigations in a case of neuroretinitis. Sometimes you might need to do blood cultures and a brain imaging, CSF analysis, if you're suspecting syphilis, CMV, and other infections involving the brain, or to rule out raised ICT causing bilateral papilledema. Now, if an infectious etiology is suspected but serologies are negative, retesting at 6 weeks for rising IgG titers might give the diagnosis. This is a patient we had, relatively young male, who presented with post-high fever. And he also gave a history of fleeting rash, which used to last only 3 to 4 hours at a particular location and then would shift location of the rash itself. He had been treated elsewhere for 6 weeks. Vitreous biopsy had been done, which was negative, and he had been treated there with high-dose steroids. This had been the picture from previous hospital, where he had been treated with steroids, antivirals, and clindamycin for toxo. So when he came to us, we started him on IV pulse steroids. There was not much improvement. As you can see, vision was slightly improved. So we again focused on the history, and we found that this fleeting rash was little unusual, and on looking up the causes for a rash that might shift in few hours, we found only 3 possibilities. So investigated for these 3, and the only thing positive was a Weil-Felix test, which was strong positive, suggesting rickettsia. So we put him on doxycycline, and within 3 weeks, there was a remarkable change in the picture with resolution, which was not happening previously with all other treatments. Multimodal imaging, fluorescein angiogram shows disc edema. SD or the OCT documents as shown a serous detachment in the beginning, later on resolution with coming in of the hard exudates in the outer plexiform layers. Prognosis in the idiopathic and most cases is good. However, recurrent attacks would adversely affect the optic nerve function. However, in my own experience, there are often cases of severe vision loss and optic atrophy, or at least image distortion, color vision deficits, reduced contrast sensitivity, and rarely reported are macular hole, vein occlusion, artery occlusion, even neovascular glaucoma, or just secondary glaucomas, not neovascular, with corneal decompensation. Prognosis of infectious neuroretinitis is variable and depends on the organism. Herpetic infection has been reported to cause severe necrotizing infection and loss of vision. So treatment of idiopathic may not require any treatment. However, systemic steroids are given and may hasten the recovery without altering the final outcome. In case of recurrences, steroids initially and then long-term immunosuppression, even with azathioprine, which is a mild agent, may prevent recurrences. Infectious neuroretinitis, specific to the infection suspected, but if there is a broad spectrum choice, fluoroquinolones or azithromycin are good enough. In children, sulfamethoxazole, trimethoprim combination, or azithromycin, sorry. When we suspect these Lyme disease, rickettsia, leptospira, doxycycline seems to work better than ciprofloxacin or azithromycin. My personal choice is to use a fluoroquinolone levofloxacin having the best bioavailability, which covers for most organisms while we are still investigating the patient. Levofloxacin, and then later on, as the test results come in, we can change the antibiotic. In immunocompromised, these antibiotics may be required for prolonged periods. Differential diagnosis is for any disease that can cause optic nerve edema, like papilledema, ischemic optic neuropathy, neuritis, compressive lesions, and others. Also, bilateral disc edema with macular star could be from hypertensive retinopathy grade 3 and 4, which can also have a serous detachment of the macula. So blood pressure check should be very important before starting investigations. And raised intracranial pressure with severe papilledema can also cause exudates, but those are generally localized around the optic nerve and not as a macular star, though that could also be there. Posterior scleritis can look very much like neuroretinitis. I've seen some patients, but the only giveaway is very severe pain and headache. They can have disc edema and peripapillary exudates, but OCT and B-scan will show choroidal thickening, choroidal elevation, retroscleral fluid, enlarged optic nerve sign. So these will distinguish it from a neuroretinitis. This patient is a syphilitic posterior scleritis that looked very much like neuroretinitis. On treating for syphilis, the entire headache, pain, everything resolved. Thank you.
Oh, thanks, Mallika. That was a very extensive, wonderful talk.
Thank you.
Ashay, I think we can just take one question or a very small question. We have 5 more speakers, and I'm sure all of them are wonderful to be heard.
Yeah, I think the madam has covered everything. Nothing
Yes.
left for me to ask. Just a small subacute variant of DUSF. So there, there is a worm involved. So
Yeah.
so it is, unless it manifests with the Garcia sign and other signs, it is very difficult. Any pointers to rule out at presentation where there is no macular star?
Yeah, I think migrating lesions and multiple lesions coming at different times, chorioretinal lesions actually, might give the diagnosis. Then you have to look very carefully for the worm. It's not very clearly visible also. I have not seen it, but even the reports which I have seen, the worm is not even very clear in their images. So, but I think the clue would be repetitive lesions in different areas not responding to regular treatment. And laser for the worm is what is advised.
Thank you, Dr. Mallika.